chapter 62, 63. Chapter 62 is going to provide you information with care of the patients with kidney disease. Okay, so when you're studying, you need to think about the disorders as kind of classifying them in one of three categories. Okay, we've talked about inflammation and infectious disorders. Okay, so the disorders that have itis at the end of them, basically. Okay. Then we have those obstructive disorders, stones. We're going to talk about sclerosis and those types of things. And then we have that other category where we have the trauma, the cancers, those types of things. Okay? When you're studying, you need to keep in mind always the basic function of the kidneys. Okay? They are to excrete hydrogen ion, reabsorb bicarb. They play a role in red blood cell formation because they produce a hormone called erythropoietin. And then vitamin D activation. Okay, so anytime we have a patient, okay, that has had some type of kidney function impairment, we need to look at, okay, what's happening with vitamin D? What's happening with the red blood cells? Okay, and I had a win this week because I have taught this content for a long time. Okay, and I will tell you, students get to other semesters and they will take care of patients and they will have a situation and the faculty will ask them a question and they'll be like, oh no, I've never heard of that. And the faculty will come back to me and I'm like, they're lying because we went over that in class. Okay, but this past week, I had a faculty member come to me and she said, I wanted you to know that I gave a student a patient and the patient was anemic. And they were ruling out a GI bleed. And she asked, what's going on with this patient? Because, you know, they're anemic, they've got a low hemoglobin and hematocrit, but they don't have a GI bleed. And the student said, well, their BUN and creat are really, really high. It could be because of their kidneys. And I was like, somebody listened and remembered. Hallelujah. Okay? So when you're in clinical, okay, and you see a low hemoglobin and hematocrit and the patient is anemic, okay, yes, number one, we need to think they've lost blood. Okay, but if they haven't lost blood, then we need to think about, okay, are their kidneys malfunctioning? Because that erythropoietin is required for red blood cell formation. Okay, if that isn't happening, they're going to be anemic. Okay, what's an anemic patient look like? What do they look like? What kind of symptoms do they have? Pale. Cold. Short breath. Okay, because what do red blood cells carry?
Oxygen.
Oxygen. Okay, so you guys, this is what I'm talking about when I say application. Okay, there are billions of pieces to the puzzle and you have to be able to put them together. Okay, so oxygenation. Okay, could I be in with a fracture? Okay, vitamin D absorption disrupted. Okay, what else does an anemic patient look like? I don't have enough red blood cells. Fatigue. Malaise. Okay? All right, so priority concept has not changed. We are still trying to eliminate. What are we trying to eliminate? Hydrogen ion. Okay? Our interrelated concepts, fluid and electrolyte balance, acid-base balance, because, why? What's the role of the kidney?
To reabsorb bicarbonate.
Reabsorb bicarb, okay? And then we have immunity. Where does that come in? red blood cell formation and keeping everything oxygenated, vitamin D, all of those things. And then pain.
What was with the red blood cells, you said there was a protein?
Erythropoietin. Erythropoietin, okay? Because a lot of times, if we have renal patients and they're on dialysis, they will actually come into the hospital frequently for a erythropoietin injection, an Epigen, EPOGEN injection to help stimulate red blood cell formation. All right, so we're going to talk about pyelonephritis. Okay, pyelo meaning kidney. All right, it's a bacterial infection that starts in the bladder and moves upward to infect the kidneys. We have two different types, acute versus chronic. And then unfortunately, abscesses do develop on the kidneys, or can develop. Okay. With acute, this is usually because of an infection resulting from obstruction or things backing up. So what could cause an obstruction? Stones. What else?
Or would cats be considered a stone?
No, but CAS would kind of move that bacteria upward. So a non-sterile catheter insertion could be a cause. What else? What? In a far-fetched way, kind of. Okay? But what else could cause an obstruction? What kind of things could cause the narrowing, what's that called, of the vascular system, of our vessels, okay, of the ureters? What's that called? Sclerosis. Okay, sclerosis. I could have a genetic anomaly where I have strictures. Okay? So chronic usually occurs with the structural deformities, urinary stasis. What causes stasis? What type of incontinence? Overflow. Very good. Okay, obstruction and then reflux. Most common bacteria is E. coli. Incidence and prevalence? Young women, okay, who are sexually active. Okay. Does that sound very similar to something else we talked about last week? Cystitis, right? Okay. Happens in women, sexually active. Okay. Pyelonephritis can also be very common in pregnant women, especially in the third trimester or the second. Why do you think that is?
Decreased blood flow because it's going to the womb or the uterus?
Not decreased blood flow. It's more pressure. Okay. As well as sometimes our moms in their second and third trimester start to have high glucose levels. Okay. And glucose feeds bacteria. Okay, our history. We want to know about recurrent UTIs. Okay, because remember, this is a bacterial infection that has started in the lower region that has moved its way up to the kidneys. Because remember, our kidneys are supposed to be a one-way system. Okay? So, diabetic patients, if they've had stone disease, and when we think about stone disease, we need to think about more than just kidneys. Okay? Because gout, hyperparathyroidism, diabetes, all of those things we need to be thinking about when we're thinking about stone disease. Okay? Reduced immunity, and then their overall kidney function. One thing we always want to make sure if we have a patient and we're getting ready to do a KUB upright or any type of basic x-ray radiologic exam, we want to make sure that they are not pregnant, okay? Because we don't want them getting radiation to that fetus, okay? So we always want to make sure in our screening questions that we ask, are they pregnant? And they will usually do a urine pregnancy test just to make sure that the patient is not pregnant, okay? Then we want to look for flank and CVA or CVT, okay? Remember our costovertebral angle tenderness, okay? And then psychosocial assessment, okay? Because remember, the anxiety, the embarrassment, the guilt, okay? They may not want to forfeit all the information. So we really have to ask those questions tenderly and not judgmentally, okay? And provide education. Our lab assessment, okay? If we look at this lab assessment and then go back and look at our cystitis, they're going to be the same, guys. Okay, so in that respect, it's very similar. Okay, we're going to do that KUB, right? But one of our other things we're going to look at is an antibody-coated bacteria in the urine, and then a radionuclide renal exam. Okay, so like an IVP. When we're looking at our patient, things that we want to notice, that flank pain. Okay, remember we talked about flank pain, back pain when it's the kidney, and then abdominal pain, lower pubic pain if it's the bladder. Okay? This is where we start the potential for chronic kidney disease. Okay? Because if this is not treated and they continue to have recurrence, the damage starts to be done and those cells start to die and become impaired. And then this is kind of like the start of chronic kidney disease. Okay, so we want to make sure that we're getting it treated properly. So with pyelonephritis, managing pain, non-surgical. What are some non-surgical things that we could do? It's an infection.
Antibiotics.
Mm-hmm. Antibiotics, fluids. Okay. Surgical management might be what? If it's caused by an obstruction.
Repairing it or getting out what's causing it.
Louder.
Repairing it or getting out what's causing it.
Yeah. Figuring out what the cause of that stricture is. So maybe a stent, removing that stone, whatever is causing that narrowing. Okay. And ultimately, we want to prevent chronic kidney disease. We don't want him to have recurrent episodes of infection. So home care management, self-management, education, and your healthcare resources. If you look in your text, under home care management, it is page 1359. It talks about their drug regimen, making sure that they're taking all of their medicine, adequate fluid intake, best practices if they have to have a chronic urinary catheter. Because remember, we talked about they need to use a new catheter every time if they're doing an intermittent self-cath, or they need to be taught proper catheter care if they have a permanently indwelling catheter. Okay? Balance of rest, and then signs and symptoms of reoccurrence. If they start running a fever, if they start having any of the signs and symptoms with the flank pain, they need to be seen immediately. Okay? So then if you look on page 1357, it shows the signs and symptoms. Okay, fever and chills are two of the distinguishing features that you see in pyelonephritis versus cystitis. Okay, when I have a bladder infection, I usually do not have a fever and chills. Okay, When I have a bladder infection, what do I usually have? What are my symptoms? Pain, dysuria. Okay, frequency, urgency, burning. Okay, but with pyelonephritis, okay, it's moving up to a larger organ structure, and it's becoming more systemic. Okay, so we get the fever, the chills, the flank pain. Sometimes they'll have tachycardia, so we'll start to see cardiac symptoms. If I have just a bladder infection, I don't have all that. Okay? So, evaluation, we want the pain to be controlled. Okay, so they may take Tylenol. Okay, remember Tylenol has antipyretic properties, so it can help with the fever. It's also a non-steroidal, so it can help with inflammation and pain. And then we want them to be knowledgeable about their disease and their treatment interventions, because we do not want it to progress to chronic kidney disease. With chronic kidney disease, they may end up on dialysis, okay, or need a renal transplant. Okay, then we're going to jump to glomerulonephritis, okay? And the first one we're going to talk about is acute glomerulonephritis. And this is one that, even though it ends in an itis and it is caused, it's related to a bacteria, it's actually an immune-mediated response. Okay? So when a patient gets acute glomerulonephritis, it's as kind of a secondary response. It's an immunity response to the fact that typically I've had maybe a strep infection 7 to 10 days before, and then my body has this immune response where it tricks my body, and I start to have issues with my kidneys. Okay? So it's an antibody antigen immune response. The cause is usually infectious. Like I said, it's usually strep. See, page 1359 shows you all the different types, but a group A beta strep is the most common. Okay? Pneumococcal, syphilis, varicella, hepatitis, Epstein-Barr, HIV, they're all listed there, but your most common is strep. Okay. And it's usually gone untreated. So when we're assessing them, we want to know, have they had any recent infections? Okay, any illnesses, any surgeries, their history of systemic diseases. Okay, hypertension, diabetes, gout, any of those types of things. And then we want to inspect their skin for lesions. Okay, why are we inspecting their skin for lesions? Yeah, that could be the source of the infection. Okay, so a lot of times if a patient is going in for surgery, that's one of the questions they ask. Do you have any like a pimple on their back? Okay, because a lot of times MRSA, staph, strep are on our skin. Okay, and they may be in a wound like that the patient has all the time and they don't think anything about it. But I've seen surgeries canceled because of a lesion like that on a person's back, because of the source of bacteria. Okay, so we need to know, do they have those? And then edema. Okay, any puffiness, any swelling. And we can ask, how are your rings fitting? What about your shoes? Do your shoes feel tight? Tighter than normal? Okay, look at their eyes. Look for puffiness in their eyes. That's called orbital edema. Okay, see if their eyes are puffy. Okay, and then we want to look at their blood pressure. And what will we expect their blood pressure to do? Go up or go down? Go up. Okay, go up in renal disease. Decreased volume, but what system? What gets activated?
Renin.
The renin system gets activated. Okay, anytime I have renal disease and I have decreased blood flow to the kidneys, decreased perfusion to my kidneys, the renin-angiotensin system gets activated. Okay, my blood pressure is going to go up. Okay, so we're going to look at our lab values, okay, and our diagnostics. Okay, it's the same thing, guys. Okay, your analysis, albumin, creat, BUN, GFR. Okay, our diagnostic assessment, we're going to take a piece of that kidney. Okay, we want to assess the kidney. Our actions, manage the infection, prevent complications, and provide appropriate patient education. Okay. Important patient education, take all your medicine. Increase your fluid intake. Okay. Maybe restrict some things in your diet, like sodium, caffeine, alcohol. Don't smoke. Compared to chronic glomerulonephritis, okay, and this happens over years, okay, and I kind of view this as almost like a silent killer, okay, because this is kind of happening behind the scenes over periods of time. And damage is being done, but we don't know about it until there's been significant damage and I start to have signs and symptoms and repercussions of that, okay? So I start to have protein in my urine, hematuria, hypertension, fatigue, and then occasional edema, okay? That my rings are too tight today, okay? My shoes feel tight. The exact cause is not really known for chronic glomerulonephritis, but we think recurrent infections and damage. So we always want to know, what are their health problems? Okay, and we look at diabetes, hypertension, liver disease, all of those chronic conditions, heart disease. Have they had a recent exposure to infection? Do they have fatigue, lethargy? What are their elimination patterns? Okay, do they go frequently? Or do they maybe only go once or twice a day? And then we're going to look for the systemic circulatory overload. So there's the fluid that Maza was talking about, the lung crackles and uremic symptoms. Okay, what are uremic symptoms? What does that mean? What would we be looking for? What? Tremors? Could be. Okay, because remember, we start to get irregular acid-base imbalances. What's my skin going to look like? Not necessarily yellow. Remember, jaundice is with what? Liver. Okay? Flaky. Dry, flaky skin. It starts to thin. Okay? They may be pale. Okay, why would they be pale? Why would they be pale? Why would they be pale? Decreased oxygenation because of decreased red blood cell formation. And what else? They could bruise easily. Okay. And then we're going to look at the psychosocial assessment. Okay. The uncertainty, the loss, the fear. Okay. Because we don't know what's causing it. Okay. But we do know if it doesn't slow down or stop, they're going to end up on dialysis, okay, or in kidney failure, okay, with chronic kidney disease. So our diagnostics all stay the same. So then we're going to take action. Okay, we want to slow the progression of the disease, prevent complications. Okay, so we want to make sure that they've got good hygiene, that they are taking in about 2 liters of fluid per day and 2 liters of water, not a lot of caffeine, soda, sugary drinks, high carbon things. Why do we avoid carbon? Like carbonated beverages. What makes the carbonation? Phosphorus. Okay. We may have to have some dietary changes. Okay. Specifically sodium and protein. We talked about fluid intake, their drug therapy, and then eventually dialysis or transplant. Okay, that's where that uncertainty comes from. Okay, because am I going to be a candidate for transplant? Is that within my control? No. Okay, because can just any kidney go in my body and fix my problem? No, I have to have a match. Okay, and then can I live forever on dialysis? No. No. What happens when you go on dialysis? Or what is dialysis?
They filter out the blood. The machine filters out the blood for you.
Yeah, so I'm hooked up to a machine that filters my blood. And how often does that have to happen?
A couple times a week.
Yeah, usually about 3 times a week. So is that a outlook on life that is a real positive outlook? No, that really limits your ability to be independent, doesn't it? Okay. So that's where that uncertainty, some anxiety, some fear, some depression could come into play. So then we're going to talk about nephrotic syndrome. Okay, and nephrotic syndrome is a condition where we have the permeability, okay, of the glomeruli are impaired, so much so that basically I envision it like Swiss cheese, and the protein molecules are released through that. Okay, and then you get massive, massive amounts of edema. Okay, you guys know what I mean if I say the Michelin Man? Or the Stay Puft Marshmallow Man, like in Ghostbusters, that big marshmallow thing. Okay, that kind of image, okay, is what I think of when I think nephrotic syndrome. Massive, massive amounts of edema. Okay, fingers and toes don't even look like fingers and toes because they are about 10 times the size they normally are. Okay, faces don't even look like the person is recognizable because they can barely open their eyes because there's so much facial edema. Okay, their arms, their legs, their abdomen. Okay, massive, massive, massive amounts of edema. Okay, we usually see this in adults. However, it can happen in pediatric patients, and a lot of times people will say, "Oh, look at those little chubby cheeks and those little fat rolls." And they don't know that the kiddo has nephrotic syndrome. They think it's just a chubby baby, but it really, truly, in fact, is nephrotic syndrome. Okay, because their kidneys have shut down. Okay. The most common cause is the altered immunity with inflammation. Okay. So we see massive amounts of protein elimination. So we see severe proteinuria. Okay, so massive, like off the chart amounts of protein in their urine. Okay, tons and tons of edema. Okay, so what do we do to treat it? ACE inhibitors. Okay, so what are your ACE inhibitors? You guys got to pull back pharmacology. Do you remember any of them? Do you remember hearing about the prills? Okay, captopril. Okay, Zestril, lisinopril. Okay, those are all examples of ACE inhibitors. So our patients would be on ACE inhibitors They're going to get heparin, dietary changes, okay, sodium, protein, glucose. They may get mild diuretics, okay, that sodium restriction, and then we're going to really monitor their INO, okay, because all of this fluid is kind of what I call third spacing, okay. It's going into the interstitial, okay, causing edema rather than staying within the vascular system, okay. There's not a whole lot, like your section on nephrotic syndrome is teeny tiny, but it's hugely important, okay? The next section is nephrosclerosis. Okay, we've kind of already talked about this because we've talked about sclerosis. And remember, any vessel can sclerose, just like we have atherosclerosis, okay, sclerosis of the vessels of our heart, okay, the vessels of our kidneys can sclerose as well, okay. So our blood vessels thicken, we get the narrow lumens, okay, decreased kidney blood flow, decreased perfusion equals the renin-angiotensinogen, my blood pressure goes up, okay. We can see it with hypertension, atherosclerosis, and diabetes, okay. It may be reversible or progress to end-stage kidney disease, end-stage renal disease. That's probably what's going to happen, okay. Which then equals what? End-stage kidney disease says eventually I'm going to have one of three things. Dialysis, transplant, what's the third? Death. Okay.
Quick question.
Uh-huh.
So it occurs with hypertension, or can occur with hypertension.
Right. Hypertension because of heart disease, atherosclerosis, heart disease. Okay.
But it also causes hypertension.
Yes, because of the decreased blood flow.
In the rounds.
Yes. Okay, so I may be on a blood pressure medicine because I have cardiac disease, but that blood pressure is not working very well. Okay, because I've got nephrosclerosis, and even though I'm on an antihypertensive, it's not working because my kidneys are sensing decreased blood flow. I need to increase perfusion, and I increase perfusion by increasing my blood pressure. So it's kind of like this counteractive thing that's going on. And honestly, that's why we see a lot of renal disease with our cardiac patients and our diabetics. Okay? Because remember, diabetes does what to all of our vessels? Darla talked about diabetes with fluid and light. What does...
They lose elasticity and constrict. And
Yeah. So you have at little bitty minutia vessels, okay, they stop working. Okay, so the vessels in my eyes, because of diabetes and that high blood sugar, those vessels stop working. Okay, in my heart, in my gut, all of my peripheral neuropathy. Okay, because at the very, very tiniest level, those cells start dying because of the damage from diabetes. So what do we want to do with nephrosclerosis? Control the hypertension. Okay, so this is where we're going to see the addition of diuretics and then the ACE inhibitors. Okay, and the most commonly used are those that fall under the Pril category. Captopril, Vasotec, Lisinopril. You guys probably are giving tons of Lisinopril in clinical. All right? And then we're going to watch for reduced albumin in the urine. Okay, our goal is that we're not going to be losing all of our albumin. Okay, so remember, albumin is our equate to protein. Okay. Then we have our first true genetic disorder that we're going to talk about. Okay, so we've had in the other category, we've had our acute glomerulonephritis, okay, which is an immune-mediated response. Now we have a genetic disorder where I develop these little pustules on the outside and internally to my kidney. So when we look at that picture that was the very first slide, okay, that's an example of a kidney or a pair of kidneys with polycystic kidney disease. Okay, so if you look at that and you think, I wonder if those kidneys function very well, what's your answer? No. Okay, because what's going to happen? All the kidney functions, the functional unit of the nephron gets disturbed because it's got all of these cystic pockets that are being formed. Okay? So, do I have hypertension? Yes. Because why? Can I have good blood flow when my kidney looks like that? No. So blood flow is disrupted. Okay, abdominal fullness and pain. Why would I have abdominal fullness and pain? Because of the cyst. The kidneys start to enlarge a little bit. Okay, because they're growing with these cystic pockets. Okay, cysts can bleed, so the cyst will fill and they will rupture. Okay, and internally they can rupture, so you'll have bloody urine, so you'll have hematuria. We can get kidney stone formation, infections, and then systemic disease, okay, where it's then going into that uremic state. So as I mentioned, it's an autosomal dominant trait. Okay, I'm not going to quiz you on that, okay, or you're not going to test you on that, but you do need to know that it is a genetic disorder. Okay? And it's the most common inherited kidney disorder. Okay. It affects all ethnic groups in the U.S., and it affects men and women equally. Okay. Versus when we looked at pyelonephritis and cystitis, did we have a difference? Male, female? Yeah, who was it occurring most frequently in? Female. Okay. We don't see that with polycystic kidney disease. Okay. So when we're taking their history, we do want to explore their family history, okay? And we may want to do some genetic testing. Unfortunately, a lot of families, they don't talk a lot about kidney and renal health, okay? Because, I mean, when you're sitting down and you're talking to mom or grandma and grandpa, do you ever really say, so, how's your urination? We don't talk about it, okay? And then they get sick, they go to the hospital, they pass away, and they may say, oh, well, they had heart disease. And then maybe somewhere down there it says kidney disease. But we really don't know what kind. Okay? We want to know, do they have a history of pain, constipation, urine changes, hypertension, and headaches? Why headaches? What's the link there with headaches?
Fluid retention.
Fluid retention, and then your acid base, as well as your fluid and electrolyte abnormalities. Okay? Because we can start to see neurological changes as we start to have acid-base imbalance disturbances and fluid and electrolyte disturbances. Okay. And then our physical assessment. They may have bright red or cola-colored urine when the cyst ruptures. Okay. And then again, that uncertainty, the loss, the fear. Okay. Because what's going to happen? What are my three treatment options? Dialysis, transplant, death. Okay, is that a positive outlook? No. Okay. Diagnostics, very similar to what we've had before. We're going to use ultrasound, MRI, CT, UA. And then what are we going to do? We're going to manage their blood pressure, manage their pain, try to prevent constipation, and then slow the progression of chronic kidney disease. Okay, so slowing it by managing their blood pressure, trying to maintain as much perfusion as long as possible. Okay? There are some really great health resources. The National Kidney Foundation is huge. Okay? So if you, by chance, do encounter a patient in clinical that has chronic kidney disease, okay, I encourage you to check out at least the National Kidney Foundation. Okay, your book lists all of those and a couple more, but the National Kidney Foundation has some really, really good resources for patients and for students as you're learning new content. Okay, questions so far?
Preventing constipation.
So when we start to get fluid and electrolyte abnormal things going on, what electrolyte affects peristalsis?
Yes.
Okay.
Gotcha.
Okay. Does that make sense? Okay, and again, that's application. Okay, potassium, calcium, those all affect neuromuscular involvement. Okay, so we start to see abnormalities. When we look at end-stage renal disease, okay, the number one electrolyte we need to be worried about is potassium. Okay, because if my kidneys start shutting down, okay, all of these electrolytes are going to start building up. Okay, what happens in hyperkalemia? Cardiac arrest, death. Okay, so if I'm going to look at any of those electrolytes, okay, the number one that I'm going to worry about is potassium. Because if I am not on top of a potassium that's starting to climb, my patient can go into cardiac arrest. Okay, and Darla talked about what's the treatment for hyperkalemia. What do we do? What? Glucose, insulin, and we do it IV. Okay, because we have Kxalate, right? Okay, but if I got a 7.2 potassium, do we want to wait for Kxalate to work? No. No. Okay, and this is kind of jumping ahead because we're going to talk about dialysis in a little bit. But my girlfriend in college, her mom was a recipient of a kidney transplant. Okay, and she got her transplant while I was in nursing school. Okay, so almost 30 years ago. But she went in several years ago for outpatient bunion surgery. Okay, basic outpatient surgery. Came home, within a week, she was dead. Okay, because she received nephrotoxic medicine, anesthesia, when she was in the outpatient surgery. Okay, it shut her kidneys down. Okay, she started to have all the signs and symptoms of hyperkalemia. Okay, she called her husband and said, something is really wrong. Can you take me in? They figured out that she had hyperkalemia, but while they were explaining to the family, we're going to have to do some rapid dialysis, this is what's going on, she coded and died. Okay, so when I say look at their history, look at their meds, okay, ask questions, you guys. If you see medicines that are not typical medicines, and you're not familiar with them, say, well, why are you on this? Okay, because on her med list were transplant rejection drugs. Okay, that someone should have said, why are you on this? Okay? Don't you think there should have been a big red flag on her chart that said, transplant patient? Okay? Yeah. Okay? So when you're assessing, you have to be thorough. Okay? Don't ever just take it as a check, 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 check. Okay? Because you're going to miss something. And if you miss something, it could result in somebody losing their life or having severe damage. Okay? That's my soapbox. Sorry. Am I passionate about it? Am I still mad about it? Yeah. Yeah. Did they sue the hospital? No. But I'm like, somebody ought to lose their job. They killed your mom. That's how I viewed it. Okay? I'm like, she was like, well, we talked to the hospital. They're doing education. Okay? I still hold a grudge. It's been 20 years. Okay? Because I expect better from our profession. Okay? Somebody dropped the ball. Multiple somebodies dropped the ball. Okay? Hydronephrosis and hydroureter. We talked about this last week. Okay, and I talked about when a stone starts to block, everything starts to build up. Okay, so hydronephrosis, we start to see an enlargement of the kidney. And then if the stone is blocking here, we see hydroureter. Okay, so the ureter starts to expand and swell as well as the kidney. Okay, so how do we recognize it? We're going to look at their history. Frequent UTIs as a kid because they may have scar tissue. The flank and abdominal pain, chill, fever, malaise, because what's starting to happen? Yeah, infection. What do we call it? You know it. It's right there. Yeah, pyelonephritis. Pyelonephritis. Okay. The pain, the chills, the fever. Okay. Tell me, it's kidney versus bladder. Okay. So you're going to inspect the flank, palpate the abdomen, use the bladder scanner because we're wanting to see. Okay. Do I have residual urine in the bladder? Okay. And then diagnostic testing, we're going to do the urinalysis, BU and create ultrasound, CAT scan. Okay, urologic, what are we going to do? Maybe a cystoscope, okay, to retrieve that. If it's a stone, lithotripsy. Okay, whatever we need to do, maybe a stent to remove it. Okay, and then that patient may have antibiotics, fluids, those things afterwards. Okay, renal vascular disease is a process that affects the renal arteries, causing greatly reduced blood flow to the kidneys. We see this usually in our people who are 50 and over. Okay. Your key feature is that difficult to control hypertension that I just talked about. Okay, because they probably have cardiac disease as well. Okay, and then because of that decreased blood flow, we can't control their hypertension. We usually also see poorly controlled diabetes, usually sustained hyperglycemia. So this may be the patient who, I'm going to use my mother-in-law as an example. Okay. God love her. But she was a diabetic. And we would go down on the weekends and I would see Coca-Cola and M&Ms on the kitchen table. Okay. Are those two things that a diabetic should have in their diet? No. Okay. And I would somewhat sarcastically say, oh, new items on the diabetic diet? Oh, I just bought those because you kids were coming. No, you didn't. Okay? You buy them all the time. Okay? They knew her by name. Like she could pull up to the drive-through window at Steak and Shake, and they knew her voice. Like we're in the car one time, and she's like, hi, this is what I want. And the little girl was like, hi, Ruth, how are you? I'm like, how do they know you here? Well, I like to treat myself. So much so that they know you by name, like your voice, the voice recognition says Ruth McCord has pulled into the drive-thru. Okay. Her glycemic control was awful. Okay. When she first was diagnosed, what's a hemoglobin A1C supposed to be? Less than 7, right? She was over 14. Okay, so did we celebrate when we finally got her to 11? Yes. Okay, and then as she started to deteriorate, okay, they told her, well, you need to have some type of, like orange juice or something for recovery. Okay, well, she doesn't really like the taste of orange juice, so she opted for orange Sunkist soda. Anybody know how many grams of sugar are in an orange Sunkist soda? I'm like, education nightmare. Okay, loved her to death. Okay, she has since passed, but so non-compliant. Okay, elevated serum creat, decreased GFR. Okay, the MRA is a medical, a magnetic, kind of like an MRI, only it looks at the vascular structure. So it's basically an angiogram of the kidney and all the vascular structures. So the MRA gives us like basically the perfect view of what the kidney's vascular structure is. And then we can have the renal arteriograph as well. All right, so treatment is going to be based on the defect and the extent of narrowing. So a lot of times they're going to get a renal stent. Okay, so sometimes if we have a blockage in our heart, what do we get? Coronary artery bypass graft. We have a PTCA where they go in with a balloon and try to open those, or we get a stent. Okay, the treatment is basically the same thing, only with our kidney, it's not called a coronary artery bypass graft. It's called a renal artery bypass graft. Okay, so the same treatment is applied that we would do to our heart to our kidney. Right. And then we have diabetic nephropathy. Okay, not to be confused with diabetic neuropathy. Okay, neuropathy is that pins and needles sensation I get because I'm losing sensation and vascular structure and circulation to my feet or to my hands. That's peripheral neuropathy. This is nephropathy, where I start to have chronic kidney disease, okay, because my diabetes is not well managed. Okay? And then I think one of our last topics in this chapter is renal cell carcinoma. Okay? We kind of already talked about this in the fact that when I have renal cancers, okay, there's a couple things that can happen. Number one, I may need to have that kidney removed, and I can function without one kidney. Okay, I may have chemo. Okay, it may or may not work. Okay, and then maybe some different types of drugs. Okay, so maybe it'll be chemo, maybe it'll be an oral. Okay, but one of the things that we notice, okay, it can metastasize to the liver, the lung, long bones, the other kidney, and the adrenal gland. We want to know about risk factors, weight loss, any changes in the urine, abdominal pain, blood in their urine, a kidney mass, and then we're going to look at all of our hematological studies just like we would for any of our others. So our goal is to prevent it, so if we can try to catch it early. Okay. And then we talked about managing complications. So if I'm getting radiation, that is laser beam. Okay, so I have to watch for skin burns. Okay, so skin care is hugely important. If I'm on chemo, what happens?
Cells die. The cells die.
The cells die.
Your immune system.
Louder.
Your immune system.
Your altered immune system. Okay. My diet, I may not want to eat anything. A lot of times patients that have chemo talk about like a metal or nickel-like taste in their mouth. So nutrition becomes a huge component for these patients. So fluid and electrolyte imbalances, hydration, protein, because they need to have protein to heal. Okay, and then surgical, we remove the kidney. Okay, so a nephrectomy. And I worry about hemorrhage, okay, because your kidneys are very vascular. So post-operatively, I worry about infection, hemorrhage, so that bleeding, low blood pressure would be signs. Okay? Kidney trauma may be caused by penetrating wounds, blunt injuries, car wrecks, football players that take huge hits to the abdomen, bull riders who get bucked off, those types of things. Okay. Sometimes you get stab wounds. Okay. People are stabbed; it penetrates the kidney. There are 5 grades, but I won't test you on that. We look at their history, the mechanism of injury. We assess pain, urine circulation. Okay, you're doing the UA, the H&H, the ultrasound, the KUB. And then we're going to look at non-surgical management. Okay, drug therapy, fluids. Okay, so things to increase perfusion. Okay, if I have had a rupture, okay, they'll go in and try to repair that. Okay. If it is severe, they may have to do a nephrectomy. They may have to remove the kidney if it is severely crushed and damaged and broken into pieces. Okay. We're going to assess for infection and other complications. So what would be other complications? What happens with trauma and bleeding?
Shock.
Shock.
Hypovolemia.
Hypovolemic shock. What else?
You're going to shock and get acute kidney failure.
Louder.
Shock causes acute kidney failure.
I still can't hear you. I'm sorry, Peyton.
Shock causes acute kidney failure.
Shock causes acute kidney failure, acute kidney injury. Okay, so decreased perfusion. Okay, but when I have bleeding and it's due to trauma, what am I at risk for? Like if I got a crushing injury, blood clots. Okay, so something that could cause decreased perfusion would be a blood clot. Okay? Questions that you have? This is a good, pretty nasty picture of polycystic. Okay, you can see why they would not have pretty much any perfusion. Okay, that kidney can't work. Okay, let's break for lunch. We will pick up the final chapter, chapter 63.